On the night the Affordable Care Act was signed, some people refer to it as Obamacare, I got up at 2 o'clock in the morning. I was so frustrated with both political parties because I thought they both had misserved the American public that I began to write. And 4 months later, I'd finished this book, Political Malpractice. I have a couple themes in the book. Number one, that we have given over to the very worst people, our politicians, the opportunity to solve the most complex domestic issue of our time. Secondly, that if we were smart about it, and if we were willing to do some difficult things, we have enough money in the system already to cover the uninsured of this country, which is about a third of our population. And I tried to describe our healthcare system and the incentives that drive it in layman's terms so that everybody could see how our system works and why it's so hard to reform from the inside. So to get started, let me read a paragraph from the second chapter of my book. On Valentine's Day 2009, Tina Chumley was wheeled into the operating room at Integris Baptist Medical Center in Oklahoma City to receive a donated kidney. That same day, her daughter Jennifer was taken to another operating room at Baptist to donate a kidney. Now, what made this so special and unusual was that Jennifer was not giving her organ to her mother, but to a stranger, Scott Clark, who was being prepared in yet a third operating room. Scott's sister Cindy was in another operating room, also at Baptist, having her kidney harvested for shipment to Barnes Jewish Hospital in St. Louis. And Scott waited for a kidney from Johns Hopkins in Baltimore. This was all part of a 12-patient, 3-state, 9-surgeon, 3-hospital domino kidney transplant, the nation's first 6-way domino transplant effort. Ladies and gentlemen, that is the peak of the American healthcare system. Miracles, technological miracles happen every day in hospitals across this country. But what is interesting is that not 2 miles from Baptist Medical Center waited some of the most desperate people in the world to be served by volunteer doctors and nurses, hoping beyond hope that the meager resources of that clinic could serve their medical needs. For if they could not, then we would begin the elongated dance of trying to find more doctors, volunteer doctors in hospitals who would take on their more complex care. So that's our American healthcare system. On the one hand, some of the very best technology in the world. People come from all over the world to take part in American technology. Now, on the other hand, some of the most desperate people waiting and counting on the largesse of volunteers. When I was Chief Executive Officer at Integris, I often asked myself the essential question: how can we as a healthcare system deliver more care to more people, keep costs constant, and improve quality? And frankly, I thought I was answering that question every day. It's only after I left my position as Chief Executive Officer that I really figured out that I wasn't. I was responding to incentives that I was given. And what I was really trying to do was to beat the heck out of my competition. I was not trying necessarily to improve health care across the community because I was paid to ensure the success of my own organization. And our hospital, like hundreds across this country, focused on how they do well for their hospital, often leading them to institute marginal clinical services with marginal results. Let's talk a little bit about how the system works and why it's so complex. First off, we have this notion of health insurance. You might know health insurance started in the 1930s as a relationship between the school teachers in Dallas and what was then Blue Cross, and emerged to become the principal benefit that you provide for your employees. It was really given its full emphasis in the 1940s when Congress passed what was perhaps the most, up until the Affordable Care Act, what was perhaps the most important health legislation, and that is the Congress gave to Franklin Roosevelt war powers, which allowed him to freeze wages in preparation for the Second World War. The national unions, not having wages to negotiate over, turned to this new thing called health insurance. And it's from that point that we count the emergence of health insurance as we know it, as a primary benefit. The fact is that employer-based insurance is a unique American product. The concept that your employer takes the risk for your health care in its entirety is not found anywhere else in the world. So I tell my friends, let me give you an analogy of what I think or how our healthcare system works. I have a daughter who loves to shop. I give her my credit card and I say, dear, you go to the mall, you pick out anything you think you want. She goes to the mall and hands my credit card to the salesperson and says, pick out for me anything you think I need. What is the result on me, the payer? You have a complete disconnect between the person or the entity responsible for paying the bill, the person receiving a benefit, the salesperson, in our case, the doctor, and the person receiving the service. That complete disconnect between those three elements is exactly why we have double-digit health inflation. It's exactly why we've seen health care escalate faster than real wages for the last 40 years. That very disconnect. So I've just given you two instances why our health care is uniquely American. And let me give you a couple more. The most obvious one is the tort system. Now, it's not unknown in the rest of the world that providers of health care can be sued for things they did poorly. But we've taken it to the extreme. We have every doctor in this country views every patient as a potential litigant. And the accelerator on the cost of health care is extraordinary. But here is the interesting part. In my 40 years as a chief executive officer of hospitals, we almost never got sued for what we did not do. We did not do the MRI and subsequently a patient came up with a brain tumor. The fact is that it happens, but it happens very rarely. But yet, we act on that fear. Here's my theory. We do have a fear, doctors do have a fear of being sued. That does cause them to over-treat and to over-diagnose because they're afraid of being sued. The fact is, it never happens. But that fear absolutely benefits us, benefits providers. The more we do, the more we get paid. So the thing we fear the most economically is in our best interest. We have an unusual history of entrepreneurship in this country. We're not really sure whether healthcare is a business, where the rules of business and profit stand tall, or whether it's a social service. Is it like police and fire, where we all share the costs through our tax structure? It's probably some of both. Let me continue my analogy for my daughter. What if the sales clerk to whom she hands my credit card not only gets a commission for selling her dresses, but the sales clerk owns the dresses? What do we know about human nature which says the motivation of that sales clerk to over-provide material and merchandise to my daughter? There's a lot of conversation today that healthcare is market-driven. If we just let the consumer have control over their own dollars, somehow this will control the cost of healthcare. Frankly, I've never believed that. There's nothing in my experience that lets me know that healthcare is market-driven, that people will be absolutely driven by their own economic best interest. The main reason is that most of us are protected from the consequences of our own economic decisions. You know, we as consumers make cost versus quality decisions all the time. Some of us buy Lexus, some of us buy Kias, but we do that knowingly. We're willing to trade some quality for lower cost. The reason I believe that healthcare is not market-driven, and let me make sure I'm clear, I think healthcare can be market-driven at the margins. I think consumers can be taught and can be incentivized to ask certain questions. Doctor, do I really need that MRI? Or could I go over here to this MRI station because I've read on the internet it's $100 cheaper? At the margins, you can make healthcare market-driven. But it is not market-driven at its soul. When you have cancer, when you have heart disease, the knowledge gap between you and your doctor is so great that you ask the simple question, if it were your husband, your mother, your father, what would you do? And the doctor says, this is what I'd do. And you depend on that. We are not informed consumers when it comes to health care. We are informed consumers when we buy cars, when we buy refrigerators. We are not informed consumers when we buy health care. Health care can be market driven, but only at the margins. We don't die well. We don't die well. We do things in this country that happen nowhere else in the world, where the questions would not even be asked. My father-in-law, at age 77, diagnosed with prostate cancer. Now, most of the men in here know that you have very high incidence of prostate cancer among us. When you're 30 years old, you have a 30% chance of already having prostate cancer. It goes up 10% a year. By the time you're 70, you have a 70% chance of prostate cancer. More men die with prostate cancer than of prostate cancer. So at age 77, it is recommended to my wife's family that we do a total prostatectomy on their father. Now, what's interesting is that his life expectancy is actually longer without the surgery than with the surgery. That question would not be asked anywhere else in this world. And, by the way, it's no skin off the family's nose because Medicare is going to pay for it. Why not do it? Wouldn't be asked anywhere else in the world. So, you can go at any hospital in this community and go into their ICU, and you will observe plenty of patients at death's door being kept alive at hundreds of thousands of dollars because the family simply cannot deal with the death of their loved one. You know, doctors learn in medical school that perfect health is the slowest way to die. And that's very true. One of the problems that Medicare has, very frankly, is that when Medicare started in 1965 with a promise to begin at age 65 for all of us, that most people died, the life expectancy was in the high 60s. So actuarially, it was a very small risk for the government. We have been so successful as a medical system in treating people and keeping people alive, that is, while it's exceeded its actuarial estimates and is about to bankrupt the country. And the fact of the matter is, and here's the interesting dilemma, if we keep you alive today with some extraordinary medical technology, you're going to die of something more expensive to treat later on. We don't get out of this place alive. And the longer we live, the more we cost. The president said, and I agree with this, in one of his speeches before the Affordable Care Act was signed, that we ought to only pay for what works. We all know, I think we can agree with that. The fact is, we pay for a lot of things that don't work, that are perhaps unnecessary. The statistics that we all see is about 30 to 40% of what's done to us is unnecessary. There is tremendous variation in how patients are treated. If you look between here and Tulsa, 90 miles away, you can see tremendous variation in surgical rates. Maybe a 20% difference in hysterectomy, maybe a 30% difference in open heart. With the same demographic population, the kind of variation. In a science, in a field that is supposed to be scientific driven. In my opinion, and this is one of the things that if I were king I would institute, we have got to focus on doing things according to policy. Excuse me. We got to focus on medical protocols. Every medical school and most every specialty in this country has protocols on how patients can be treated. We always have to give doctors the opportunity to opt out of the protocols, but if we're ever going to solve this variation problem, we've got to go to medical protocols. We have unusually high overhead in this country. 25 cents out of every dollar goes to collecting a bill. In our trillion-dollar system, 25% goes to collecting bills. Every doctor has people in their office who do nothing but collect bills. My organization has an army of people who do nothing but collect bills. And let's be clear what the system is. The system is sending an insurance company a statement for services rendered. The insurance company reviewing that statement and comparing it to the benefits in the policy and issuing a check. In my opinion, that ought to take a week. It takes, at best, 3 months. At best, 3 months. In my opinion, the reason it takes at best, and my apologies to those in health insurance in this, the reason it takes so much is because that's their incentive. Their incentive is not to pay us quickly. Their incentive is actually to pay us slowly, because they are counting on the time value of money. And the more they can delay, the more profitable they are. You and I are part of the problem. I interviewed a lot of doctors for this book, and almost invariably the doctors told me that they feel compelled to do something for the patient even when doing nothing would be better. Because they tell me that if a patient leaves their office without a lab test, without an x-ray, without a prescription, they feel cheated, and the doctor can sense that. Why do you think pharmaceuticals advertise prescription drugs on the television over the head of doctors to you, the consumer, directly? They know that because 80% of the time when you ask for a drug by name, the doctor's prone to write it. And why is that? Because it would take 20 minutes to explain to you why you don't need this particular pill, and they don't have 20 minutes. What we pay doctors for is their time. And if they take 20 minutes to explain to you every prescription that you've seen on the internet or on television, that's 1 or 2 patients less they can see a day. So the pharmaceuticals have figured that out. And finally, the reason that I feel that healthcare has deteriorated into an ideological argument is that we have been governed by sound bites. I invented a disease for this book. I call it the Pelosi-Palin syndrome. Now, those two women could not be further apart politically, but to me, they're the same side they're a different side of the same coin. They view every intellectual thought on their 30-second soundbite. That's all the more intelligent discussion they give to any complex concern. And that has simply radiated into our health policy discussions, where it is simply ideologically driven and not common sense driven. So let me give you an example of some of the things that we often hear that sort of lead us down some rabbit holes. We have the very best healthcare system in the world. What on earth would entice us to say that we have the very best healthcare system in the world? I just told you we've got marvelous technology. People come from all over the world to visit our hospitals. We have the very best healthcare system in the world. We don't rank near the top in any statistical category. We rank near many third world countries in many of our statistical categories. Why would we say that? The problem is once you say it, you've cut off debate. Why would you change the best? The only thing we lead the world in is cost per capita. That's it. We're number 1. Death panels. I love the death panels. Both sides have used this death panel argument. We're all familiar with the commercials that personify Representative Ryan trying to push his grandmother over the cliff, and the Democrats wagging their finger. You know, this is what you old folks are in for if the Republicans get elected. And the Republicans have been just as bad. When you all recall when the New York Times notified us that the Obama administration had decided to pay doctors for end-of-life discussions with their patients, it hit the fan. The Democrats were appalled. And the Republicans were even more outraged. How can this be? Now here's the interesting part. Every state in this union, including this one, has a policy that each of us ought to go to a lawyer and have an end-of-life discussion with the lawyer. We ought to have a living will. We ought to have power of attorney. Someone ought to know what our wishes are. So we're willing and encouraged and incentivized to pay our lawyer, but we don't want to pay our doctor for having the same discussion. That's absurd to me. Healthcare decisions should only be between you and your doctor. All of us want a trusting, warm, loving, confident relationship with our physician. But you could make the argument that healthcare decisions should only be between us and our doctor, is what got us here in the first place. I'm old enough to remember Laetrile. Remember Laetrile? The juice of apricot pits. You had to go to Mexico to get it. And yet there were lots of doctors in this country that prescribed Laetrile. I got to get back to evidence-based medicine. We ought to follow the protocols. It's the only way we're going to help reduce cost. And as you listen to the politicians talk, I want to give you a simple formula so that you can figure out whether you think they're going in the right direction or not. The formula is simplistic, but the mathematics of it is very true. The quotient, in this case, is the cost of health care to you, the employer, or to the federal government. And it's made up of several multiples. One is the number of people in the plan, obviously. Two is the number of benefits. You know, what's the deductible, what's the co-pays. Three is what you pay providers. And four is the number of times you use those benefits, how many times you go to the hospital. Now, if we're going to raise the number of people and keep the quotient constant, what do we got to do? We got to lower one or the other. We got to lower provider payments. We got to lower how much we use the payments or the benefits. What are politicians likely to cut? Well, what they're likely to cut is provider payments. And over the next several years, watch the fight between doctors and hospitals over cutting payments as we increase the number of people in the plan through the Affordable Care Act. It's mathematically sound. You can't have your cake and eat it too. Let me spend just a couple final moments on the controversy that has been most recent, and that's over the mandates, both the individual mandate and the employer mandate. Recently, I saw a young man riding a motorcycle at a very high speed with no helmet, smoking a cigarette. And my initial thought was, I bet he's uninsured. You know, and that's the person that the individual mandate was aimed at. It's aimed at the person who's irresponsible and has no coverage. And get them, those are the people that are gaming the system. Now, it is true of the third of the country that's uninsured, about 19% of them make more than $75,000 a year. That is a group of people that obviously could afford health insurance if they wanted to. That's also what the mandate is. It's people that are gaming the system. Now, I won't speak to the constitutionality of it or even the logic of it, but that's clearly who it's aimed at. It's people that are taking advantage of each of you, that are taking advantage of your employers, employees, and their policy cost. Employer mandates. I will tell you, my theory is that with only a few years, we're going to see the death of employer-based insurance. Because here is the decision most employers are going to have to make. I can either continue to provide health insurance to my employees, or I can send them to the internet and let them buy it themselves and pay the fine. After all, it's the same money. And after all, I get rid of a human resource headache. How many of you had to explain to your employees why you've had to raise premiums? How many of you had to explain to your employees why you've cut back the network that's provided just to save cost? Or you've had to raise deductibles, or you've had to raise copays. That's a very unpleasant experience. And employer after employer, once they determine that you can do this and the sky doesn't fall, after all, why do we provide health insurance to our employees in the first place? Well, maybe it's the right thing to do, but the real reason we provide it is you can't hire anybody without it. And once everybody's in the same boat, I guarantee you, you're going to start sending your employees to the internet. You're going to provide them with another policy which pleases your employees, and you're going to rid yourself of a huge HR headache. Now, I've got a couple of thoughts as to what I would do to begin to bring some common policy sense. And I only mention one of them due to the time. And the one is, and with my apologies to our insurance friends, the one is very extreme and maybe even a little bit fanciful. But I would begin to change the incentives for insurance companies. I would provide them a very sane and easy way to convert to not-for-profit and let them focus on other elements of insurance. And then incentivize them for how quickly they can pay, not how slowly they can pay. And begin to recapture that fourth of the healthcare dollar that goes to overhead. And then let me close by saying probably the main disappointment that I have in what's transpired so far is that the whole discussion started with how do we cover the uninsured? I challenge you to listen to both sides of this argument and find any politician who is talking about the uninsured. They're talking about insurance reform. They're talking about covering your children to a 25th birthday on your policy. They're talking about pre-existing conditions. They're talking about no lifetime reserves. The poor and the uninsured have disappeared off the argument. And I think that's where we've gone wrong. We're focusing on the wrong thing. I think we can cover the uninsured if we do some difficult things. I think we have a chance to not create a new entitlement. And let me just close with this example. In the book, I create a composite patient. And while it's not an example of any one person, it's nonetheless very true. I call this composite patient Lucy. Now, Lucy is not a bum. Lucy is not a vagrant living in a box under a bridge. Lucy has 2 children. Lucy works 3 jobs. 2 of those jobs she's a domestic, and 1 she works for a fast food restaurant. Lucy makes $12,000 a year and has no health insurance. She is too rich to qualify for Medicaid. And so she depends on one of the free clinics, 19 free clinics that are in this community for her care for her and her children. To my mind, that's where we've gone wrong. We've lost the focus, all the Lucys of this world. We've lost the focus out of doing the right thing to people that are good Americans, that are doing the right thing. They're doing everything we could ask of them to deal with their own personal situation. I know this because I'm the chairman of a group of not-for-profit health clinics, most of those in churches across this community. And we see the Lucys of this world all the time. And if I had one wish, it's that the politicians would return to the real emphasis that this whole debate should stimulate. And then that's how we take care of the Lucys of this world. So, Madam President, thank you very much for the opportunity to be here.